Hey everybody, you are listening to The Poison Lab, a show about poisoning from people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan. And I'm really excited about this very special episode. I hinted at it in the last update I provided, where I told listeners about the other podcasts I'd been on and some of the radio shows I got to do. This is sort of a year in review episode. See, I had meant to release it near the end of 2023, which is when I usually get a bit reflective and think about what's happened in the last year. But really, we should be reflecting all the time, like right now, because it's way more convenient. So let's take a look at what happened in 2023 for the Poison Lab. We've had some really great episodes. In early February, a review of bupropion toxicity, late bupropion seizures, and wide QRSs that aren't from sodium channel blockade. A wonderful episode of Toxicologist versus the Internet with Dr. Adam Blumenberg in April. A deep dive into the complexity of brain death determination and drug overdose in June. And another fun episode of Toxicologist versus the Internet with Frank Polachek in August. Followed by a few really amazing updates in toxicology. So acetaminophen poisoning management guidelines. We had the American Heart Association cardiac arrest and poisoning guidelines. And we got to do a deep dive on psilocybin. We really covered some cool topics. And today, I'd like to simmer in some of those topics. So this is a special edition episode where I've compiled all of the Toxicologist versus the Internet Stump the Toxicologist segments from 2023. So if you are feeling like scratching that itch of flexing your toxic differentials, you're going to get quite a few opportunities. Don't worry, we have more great episodes coming and I'm excited to share them with you. But for this episode, throw on your thinking cap. Take a big old swig of that lithidated 7-Up and light up an Evali vape pen. See how many of these stumps you can get right, or simmer on some of your past favorites. Let's dive in.
Episode 20, April 12th, 2023. Dr. Adam Blumenberg.
So, would you like me to read you a case first, or would you like to read the case to me first?
Why don't you read a case first?
Okay, I will read you a case. So, I think we got some fun ones. This is a very short one. Probably something you've done in the sim lab, to be honest. So we'll kick it off with this. So a 4-year-old female presents to the emergency department complaining of abdominal pain and vomiting, kind of not able to take PO. In the ED, an abdominal ultrasound ruled out appendicitis, and she tolerated sips of water and was discharged home. 15 days later, she was transported to a regional trauma center in cardiac arrest. They were doing resuscitation. They got labs back that showed an H&H of very low, like 4. Then there was some stuff done that I can't share. There was imaging. She was taken to the OR, given blood products for a large presumed bleed, and she arrested in the operating room and died.
Sad case.
It is.
Yeah.
Really sad.
So I think there are some hints as to what's going on. We can at least kind of come up with a differential. So just to kind of re-summarize, we have a child, a 4-year-old, who presents with abdominal pain and vomiting. There's a lot of things that can cause that. And then is presumably well enough to be discharged from the emergency department, followed by a 14-day essentially gap. You know, maybe is sick during this time, maybe is not. But certainly by the end of this 14-day period becomes critically ill with a severe anemia, enough so that she does not survive. So hearing a history like this, I'm thinking about toxins that can produce either hemolysis or bleeding, as well as over the course of this period of time, maybe a little bit of decreased erythropoiesis, although really it's not enough time, 14 days, to cause a meaningful anemia from that mechanism. So unless, of course, this was a longer period of toxicity than the 14 days. So things that I would be thinking about to start would be caustics. I'm thinking about lye, muriatic acid, which is just hydrochloric acid, which can cause abdominal pain and vomiting, as well as some degree of destruction to the GI tract, which could cause bleeding over the next few days if there was an initial recovery. I'm also going to be thinking about certain heavy metals, specifically iron, which can cause these types of symptoms, can cause bleeding, can cause a period of kind of very serious illness, followed by partial recovery, followed by getting sick again. I'm thinking about lead exposure, as well as both kind of acute and chronic. And then also thinking about, sadly, child abuse. So kind of repeated dosing of some other type of pharmaceutical that could cause the patient to become initially sick and then essentially poison the child again later. And that could be just about anything that could cause a shock state or bleeding.
Excellent. Dude, I'm trying to figure out how I could share more of this information without giving it away. But yeah, I mean, I think those are great. Certainly things that inhibit like hematopoiesis, certainly things we see nausea, vomiting, abdominal pain in a 14-day tragic case is colchicine always jumps to mind too, but antimitotics. But it's really hard because we have 14 days between presentation and death. We have no idea what happened in between. I would say most likely what would happen here is immediately after going home, progressively worse abdominal pain, decreased PO progressing. I'm actually very surprised to hear this took 14 days to represent. I could give you a hint.
Mhm.
An abdominal x-ray in the emergency department would have immediately diagnosed this.
I would also be thinking about with something like that would be a button battery, as well as, just sharp objects, but a button battery is something I'm really thinking about.
That would be correct. So this is a tragic case of a lithium-ion button battery. So this is what I couldn't share with you. At the Regional Trauma Center, a lithium button battery was found lodged in the esophagus that had eroded through the esophagus into the aorta. This is one that just always blows my mind. These little button batteries, and it's all about size and age. So every time I get a call from one of these, I really get nervous because of how much damage they can cause. And there's great button battery triage guidelines, I think, put out by National Capital Poison Center. But it really has to do with the age of the person, whether or not the size of the battery, the voltage of the battery. And once you can confirm it's past the esophagus, it's usually not so much of an issue. But if that is caught in the esophagus, and you can usually see it on x-ray, you need to get it out really right away because it can cause burns within 2 hours. So I don't know. Did you ever do a hot dog experiment with the lithium ion batteries?
Yeah, and there's a whole bunch of these YouTube videos of those, and it's something I've kind of shared with learners, students, and residents just to show how destructive these things can be, how quickly.
Yeah, it's just wild. So anyone at home, if you want to see the damage a lithium ion battery can cause, just cut a slit in a hot dog and leave the battery in there. It could take a little while depending on your voltage, but you should see a hot dog starting to cook. We actually recently got one of my colleagues, Matt Stanton, who's been on the show before. He got some pig esophaguses from a butcher, and we actually did the experiment with those, and it's pretty wild. Let's say you have someone who adjusts a battery. Well, I just need to rush you to the ER and make sure it gets out. But I can't really do much in the interim. Until 2018, there was a really good paper that, unfortunately for these pigs, it was really sad. They basically lodged button batteries in their esophagus and fed them either saline or honey every 15 minutes, and then let them for an hour, and then let them kind of walk around, and then sacrificed the pigs and pulled out the esophagus, looked at the damage. And the ones who had honey really had decreased burn. I think it was both surface area and depth. So that's at least one thing we have now, and that's something we're kind of adopting, and it's now in the National Capital Poison Center guideline, I think, too, to give honey 10 mLs every 10 minutes if they're greater than 12 months. It's at least something you can do to prevent further damage, which sounds like not that exciting, but it's something you can do. So I don't know.
No, I think that's super important. So where I trained my fellowship training was in Oregon, and we were the poison center for the state of Oregon, which is a fairly large and relatively sparsely populated state, especially to compare to New York or the dense northeast cities. And we also covered the entire state of Alaska. And one of the issues that we would come up would be with the issue of medevac. So if someone needed medical care to actually get them to a tertiary hospital, where might you have a pediatric gastroenterologist? It might be a 6 hour flight away. And so anything you could do to potentially temporize that or buy a little more time can make a huge difference potentially.
Yeah. Oh, I can't imagine in Alaska. You got a ticking time bomb and care is many hours away.
Hmm.
Well, I just wanted to bring that one up because I think people sometimes don't realize how dangerous those can be and want to make sure that that gets out there. Certainly, I think the public is not so aware. So hopefully they can spread the word for us. But all right, you got one for me. I'm looking forward to getting stumped today.
Sure. Okay. So I'll dive into it. So, a 57-year-old man with Asperger syndrome presented complaining of diffuse pain and generalized malaise. Mentally, he was impaired with disjointed thoughts, labile mood, and disorganized slurred speech. He denied taking any over the counter or herbal medications, and his history was otherwise uninformative. A screening basic metabolic panel returned with a chloride level greater than 175 milliequivalents per liter, which is above the threshold of detection, and an anion gap of negative 55 milliequivalents per liter. To rule out laboratory error, a repeat BMP was performed and confirmed the initial value.
Mm. All right. You're giving me easy ones. You just don't want to stump me. I appreciate it.
Yeah, good
Well,
topic for discussion.
it is. So it could actually be potentially two things. I believe this is bromism. Bromide is in the same column of the periodic table as chloride. And people who take bromide, uh, which right now the most common source would be dextromethorphan hydrobromide, could also be diquat dibromide, but I really doubt they're having fun with diquat. Or you can actually just buy bromide salt still on the internet, and some people do that. It used to be used frequently for seizures and alcohol withdrawal. They used to use it all the time. I've actually had some cases of people who are trying to detox from alcohol, and they will buy bromide salts online and take them. And then they come in with a negative anion gap and a chloride of 175. One other thing to consider here. So I'm looking based off of the description, labile mood, disorganized and slurred speech. It seems like there's some neuro effects going on here, lacking. Certainly not an anion gap, but just this makes me think of one thing. Salicylates, depending on the actual lab that you're using, some of them will actually measure salicylate ion as chloride. I believe it's a specific spectrophotometric lab. I can't recall, but there are at least two case reports I know of a patient coming in with a very serious salicylate level, no anion gap, and actually a very elevated chloride because the lab was misreading the salicylate as chloride. Then when you actually check the salicylate, it's quite high. But given the discussion here, I'm leaning more towards bromism. And what was their QTC? Do we have that? And maybe that'll lean me in on whether this was dextromethorphan or
We don't have an EKG available, but if it were available, I think it would be normal.
okay. All right. Well then I'm gonna go with bromide salts that he bought on the internet.
Yes, it's always the internet. And so you got it. This is bromide salt. And what's kind of interesting, and this again ties into just this kind of human beings are interesting people. And I am happy to say that this patient recovered completely and did well. He was buying salt from the Dead Sea. And
Wow.
I didn't know this until I read this case report, but the Dead Sea contains a very high concentration of bromide. And so the precipitated salt, uh, if you ingest that in high doses or at high frequency, it can cause bromism. And so that's how this patient got sick.
That is so fascinating. So are there people out there who just like strain the Dead Sea and or boil off the water and just have a good time with Dead Sea salt?
Yeah, so it's sold commercially. It's probably not meant to be ingested. I hope it's not marketed to be ingested. But yeah, you can buy Dead Sea salt and you can use it kind of like Epsom salts. You can soak in it, make a bath out of it.
Yeah.
Some believe it has healing properties, maybe mystical healing properties. It's
Now I know why.
yeah, reputed
You
to be good
know?
for the skin. Um, but of course, if someone's ingesting it, that's a completely different story.
Yes. All right. Well, no more Himalayan pink sea salt. I'm going Dead Sea.
Go all the way with it.
That's awesome. Well, that's so interesting. Yeah, we've had a couple cases that have needed dialysis to clear it because
Mhm,
they've been so obtunded. And then you have the whole concept of bromide withdrawal. So it's bromide, right? In your neurons,
mhm.
the GABA channel or the GABA receptor basically is a ligand gated ion channel. It means you need a drug, the GABA A channel. You need a drug to open it up. And then once it opens up, chloride rushes into the cell and makes the cell more negative, less likely to depolarize. And thus you can get, a negative excitatory effect. This is what alcohol does. This is what barbiturates, benzodiazepines, all sorts of things. They make the cells more negative, less likely to fire. Bromide acts like a chloride ion and can actually get into the cell and create this more negativity in the cell and reduce synaptic firing. So it really has the same effect as a GABA agonist. I wonder if it affects GABA receptors. I assume it gets through the GABA channel, but kind of the withdrawal is another thought to consider.
Oh,
Um,
that's a really cool thought. I never even thought about that.
yeah,
Something we see so rarely,
right.
but you know, it could happen.
I think in the 50s it was more common. Another consideration for high chloride could have been iodide.
Yeah.
Iodide itself, not iodine.
Yep.
And I don't know where you're going to really get that potassium iodide, but if you take
I
enough
guess
of that,
there. SSKI. I wonder if people are stockpiling it and just with what's happening in the past
right,
year or so.
right, yeah. Anyways, really great case. Wonderful. All right, I got another one for you.
Cool.
So unfortunately, it's tough when there's no exposure history, right? Like the button battery, we know as soon as like, oh, they're playing with a remote. Well, okay, I know exactly what to do. In the rare case where they show up and there's no exposure history, it's tough to figure out.
Yeah.
This one would also be tough to know without an exposure history. So I'm going to give you some. A 37-year-old male injected the extraction from 400 somethings mixed with acetone into his left bicep muscle in a suicide attempt. The next morning, he developed respiratory difficulties, requested 911 medical assistance, and was brought to the emergency department. He has a history of IV drug use, depression, prior suicide attempts, apparently greater than 10. His home medications include methadone, bupropion, hydroxyzine, mirtazapine, lamictal, and albuterol. On physical exam, the injection site was bruised, painful, and erythematous. His whole torso was erythematous, and he was hypoxic and complained of chest pain. He was alert and oriented. His oxygen saturation was actually low, about 80% on room air. He's placed on oxygen. His ECG was unremarkable. In lab findings, his AST and ALT were slightly elevated. Nothing impressive other than an AST ALT elevation. On the clinical course, so the patient presented to the emergency department with increased oxygen requirements. They threw him on oxygen. He sat in the hospital for about 3 days with twitching and flank pain. On day 4, he was still alert and oriented, but he wasn't really eating or drinking. He started to develop coagulopathy as well as a platelet of 53. They initiated plasmapheresis for him. About 6 days in, his blood pressure decreased. He was having liver, kidney failure, as well as pulmonary failure. It appeared. He was intubated, started on norepi, CRT, paralyzed and sedated with midazolam and hydromorphone, and then still was on multi-system organ failure. And they eventually withdrew care on hospital day 13. Whew. From this person who ground up 400 somethings and injected them into his bicep.
Hmm. That's a very unusual case.
It is, and just to clarify, I
Yeah.
would not get this without knowing exactly what they had taken.
Sure.
But I think the clue is there's 400 of something.
Yeah. Well, let's play it out. Let's talk about some possibilities. So I think the 400 of something is a big clue. So things I'm thinking about. So we have one parenteral exposure, which is a little different than a lot of our other toxic exposures, which tend to be ingestions or dermal exposures. It's presumably not a pharmaceutical. It's something that can dissolve in acetone, and it's something that over the next few days leads to multi-organ dysfunction. So starting with the pneumonitis, that's kind of could be anything that is injected into the vascular system and kind of disrupts, the lungs. That's going to be the first stop. And then over the next couple of days, really destroys or damages the liver, platelets, and coagulopathy. So short answer is I don't really know. I think there are many things that could do this that I would never think to inject into the bloodstream directly. Anything from seeds, things like rice, plant material, anything like that could contain a lot of particulates and things like that. It could be something that is a plastic that is soluble in acetone, but then when you mix it with an aqueous solution like blood, it starts to form little microprecipitates and forms little microemboli all over the body. It could be, uh, something else like a fat embolism. This could be something that contains, 400 packets of butter or something, and then this is a completely external fat embolism, which gives you low platelets and pneumonitis. So I don't think I know the answer to this one, but I'd love to hear what happened here.
That's a great differential, and I think right. I mean, you inject something in your body, you can get excipients that cause emboli in the lungs that are going to cause there used to be something called cotton fever where
Hmm.
people would strain their heroin with cotton and then get febrile and have pulmonary issues from the cotton they were injecting. So obviously this is one problem with injecting tablets too, right? You're going to get all these excipients that are going to go to the lungs, right? All roads lead to the lungs at some point, and they can get caught there and cause problems. So this was somebody who had attempted suicide greater than 10 times. I guess I'd give you a hint.
Sure.
If I give you the real hint, like you would, so for obviously it seems like it's a multi-system effect, right? So it seems to affect everything. It's so hard to do this one without saying what will give it away. You probably researched online because it's a well-known poison that's been used in a lot of poisonings, some involving Russian dissidents.
Huh.
It is a plant material.
Interesting. Okay. So it's interesting you say that. Now, let me ask you for one
Yeah.
one question. Is this plant material ever found in the tip of an umbrella? Yeah.
It has been distilled down into the tip of an umbrella before.
Okay. Um, Interesting. So, unfortunately, a creative approach to a suicide attempt for this individual who was able to complete this suicide attempt. So, what you're describing is ricin, and that's coming from castor beans. And I think the amount of ricin in 400 castor beans is certainly will do the trick if it was appropriately extracted.
That would be correct.
So you could see kind of some of those initial effects of just kind of particulate matter being injected, followed by essentially RNA inhibition over the next few days.
You hear about it every year. I see reports about it every year. I think it suffers from the fact that it's such a well-known poison kind of in the media. Wikipedia has a whole list of ricin-related events that have occurred, but they have, Georgy Markov
Yeah.
in 1978. He was a writer who I believe, I don't know if they figured out exactly who, but I think that it is pinned on Russia. I think he was writing some things that were not so great about their regime. And
Toxo here, to correct Ryan's naturally failing human brain. Markov was critical on Bulgaria, not Russia, However, the Soviet KGB was suspected to be involved in the assassination.
Somebody came in with an umbrella that had a pellet in the tip of it and either shot him or poked him in the leg with the umbrella. And then a few days later, he wound up hospitalized, multi-system organ failure, and died because there was a poison ricin pellet in the umbrella. It's also used in Breaking Bad. Walter White uses it he extracts from the castor bean ricin to try to kill Tuco Salamanca when he's trapped in like episode 2 or something. And then he also uses it again in the future to poison, I think, some family members of I can't remember the details, but it's well known as a poison. And because of that, people tend to ingest it, unfortunately, in self-harm. So, but there is a slight benefit here. So ricin, when taken orally in seed form, people, if they are trying to harm themselves, they just take a few seeds. Luckily, the seed tends to protect absorption of ricin, so you don't see much if they just swallow it. So in those cases, we usually see pretty minimal symptoms, which is nice. So they know it's bad and scary and they take it, but luckily, if they're not chewing the seed or grinding it up, they're not likely to absorb a lot. But then on the other side of the spectrum, people who know that ricin, has these effects, they will grind it up and do things like this, where they will inject it into their bicep. So I've had a number of cases of ricin, and it's interesting. It's usually a couple of seeds that are ground up, and it just causes diffuse diarrhea for like 8 hours because it destroys the GI cells, but it's not well absorbed orally. I've also had cases where people are using it for weight loss because of that. So they'll make castor bean smoothies and ingest that so that they can lose a lot of water weight via the GI tract, which I don't know if is a great idea. And for the listeners, ricin is really an interesting poison. I wanted to just walk through real quick its mechanism because I think it's so fascinating. So ricin inhibits protein synthesis. And so when you make a protein, right, you have your DNA, which is like the code, and then you take a copy of that code that's called messenger RNA, and that RNA leaves the nucleus and goes out and gets grabbed by something called a ribosome. And the ribosome is this really cool cellular machine. It's both protein, which is made of amino acid, but it's also composed of nucleotides, which are the things that make up DNA and RNA. So it's part protein, part nucleotide, full machine. And ribosomes grab that messenger RNA and they read the code. It's like, okay, if you have 3 base pairs, it's like AGG. It's like, okay, I need this amino acid and I'll add it on. So then tRNA goes and grabs the amino acid and adds it. But then it has to move to the next set of base pairs. So the ribosome has to move along the RNA, the mRNA. And the way it does that, it's an energy process, right? You need to have energy to move. So it does that by cleaving it does that using GTP, not ATP, but GTP, guanine triphosphate, I believe is that what that stands for. And it cleaves a phosphate using something called the serine ricin loop, which is this big loop of RNA that's preserved across almost all living things. So every living thing that produces protein seems to have this. It's called the SRL, serine ricin loop, that is responsible for generating the energy that helps the ribosome move along the mRNA. And this is smart of the castor bean, which doesn't want to be eaten by anything, that it generates a poison that targets something that's preserved among all living organisms. But what ricin does is basically there's this A chain on the ricin. It's a big protein, and there's this chain on it that cleaves an adenine molecule out of this RNA loop. And apparently this was where it got too complicated for me. Something about pi bonds. But when the adenine gets cleaved, the entire serine ricin loop collapses and the ribosome can no longer move forward on mRNA. So it halts transcription of proteins. Or sorry, not transcription. It halts protein synthesis at translation. The ribosome can't move, it's paralyzed. And then all of a sudden you got no proteins, your cells die. But all of your cells need to produce proteins, right? So this affects basically every organ system, although you don't see a lot of neurotoxicity until later. But I just thought that was really interesting. And then apparently ricin, or the castor bean, is so smart that ricin has a lot of lysine in it, which apparently keeps it from getting tagged with ubiquitin. That's how the cell basically tags it for digestion, because it has a high lysine content, and I guess it's resistant to that. So it tends to sit around in the cell for a long time because it doesn't get chewed up by proteasomes. So really interesting. A classic poison, one a lot of people know about, gets used in a lot of ways. Fortunately, all the cases I've ever dealt with just have led to diarrhea, not good diarrhea, very bloody, painful. But that's what we get. Oh, and then of course there's the rosary pea. We talk a lot about castor bean, Ricinus communis, but there's also the rosary pea, which contains abrin, and it's another toxalbumin that will do the same thing. And for everyone listening, recently I looked that up. That is why that happens to be at the forefront of my mind. It's not knowledge that I carry at all times in my brain. Although now maybe I will. I don't know. Super fun. And that was a big tirade. Any other comments on ricin?
No, that was really cool, and I didn't know that that kind of granularity of the biochem. I obviously how it interacts with ribosomes, but to that degree and that kind of preserved motif, that was really cool to hear about.
Yeah, isn't that neat?
Yeah.
All right. You got one for me?
Yeah. This one, it's written in a way that I'm gonna kind of paraphrase it a little bit rather than read it directly from the case report, just because I think it'll be a little difficult if I just read it off the page. So this is a case of a 19-year-old who was exercising, let's say, questionable judgment in college with friends, and they were challenging each other to do a certain activity that would be medically dangerous. And so the patient in question performed this activity, and then within a couple of hours became unresponsive, was brought to the emergency department, where he was found to be in a comatose state, completely unresponsive with seizure-like activity. And this was now 2 hours after this activity. The ER team was aware of what occurred, and so they started resuscitation. Now, I don't think I've given you enough to make a diagnosis, but maybe you could talk about some initial thoughts, and then I'll give you some
Sure.
more information.
Well, when I think of 19-year-olds challenging each other, two things come to mind: putting Tide Pods on pizza, which I guess was the thing, as well as the Benadryl challenge, trying to take as much Benadryl as you can. 2 hours. Yeah, if you take a lot, I mean, Benadryl slows your GI system, so you can have protracted symptoms. But if you take enough, it's going to absorb pretty fast as well. Other things, it doesn't sound like the ice bucket challenge to me. I don't think we're there. I'm thinking, obviously, a 19-year-old, just alcohol, challenging someone to drink as much alcohol as they could in a 30-second period, but or a 30-minute period. I wouldn't expect them to be seizing from that unless they somehow induce like a volume related hyponatremia, but I really doubt it. Like, is it a physical challenge?
It's an ingestion challenge, and I
Okay.
think everything you're saying is fantastic, because we're thinking about how to tie in this clinical medical presentation with what's going on in the world and
The
what
social history.
the
This
social
has got to
history.
be the NyQuil chicken challenge. They cook
Yeah.
chicken in NyQuil.
I'm so glad that I never had a case of that really happening personally. I don't know any toxicologists who have. I hope it never did. Maybe just to bring your listeners up, I think many may be familiar, but recently there was a large press release warning the public not to boil chicken in NyQuil and then eat it. And I think a lot of us who practice clinically started just talking with each other and saying, have you seen this? I mean, has this occurred? Um, I have not had a case. I don't know
No.
anyone who's had a case.
So I saw another news article about the FDA warning about the NyQuil chicken challenge. It was basically like FDA's warning about the NyQuil chicken challenge alerts basically everyone about the NyQuil chicken challenge,
Yeah.
that it even exists. So it's kind of like a funny equipoise. Like, did that help or hurt in this scenario? Because now more people
Yeah.
know about it. I don't, but people, it's, I don't know if anyone really did it except that one video, but
Mhm.
certainly something to be worried about because I continue to be astounded by the challenges that go on. But okay, so I
Yeah.
guess if
What
I was
kinds of
gonna
fried
peg
chicken?
on something here, I'd probably go with Benadryl. Although it almost sounds Tessalon Pearly, depending on how quickly they dropped, but unresponsive, seizing, uh, 2 hours after. But anyways, any more info I can glean here? Labs, vitals, anything?
Yeah, let me give you some more information. And I think these are all great thoughts. And as I mentioned, I don't think there's enough here to make a diagnosis without a history. But let me tell you some of the labs. So there's one particular lab which really kind of cinches it, and that's that the patient's sodium concentration peaked at 196 millimoles per liter.
Mm. Were they recently at a Chinese food restaurant?
I believe so.
Okay. This is a classic tox case that I look at all the time just because it's so fascinating. I'm gonna bet. Well, all right. So what's a sodium related seizure? I'm gonna take that as a win. Uh, this is probably someone who drank a liter of soy sauce, or maybe it was a gallon. I don't actually
Ding,
know,
ding,
but
ding. Yeah, you got it. It's a
yeah,
soy sauce.
yeah.
So unfortunately, this patient, got really sick, but fortunately they survived and did well. And we'll talk maybe in a bit about how the team saved them. Usually, if someone is, unfortunately, people do drink, large quantities of soy sauce in these kind of challenges to kind of impress friends and be goofy. And if they absorb it, yeah, it can be really dangerous and life-threatening. Fortunately, what usually happens is immediate vomiting. And if you're willing to go down a very unpleasant YouTube rabbit hole, there are videos of people attempting the soy sauce challenge and then immediately vomiting large quantities of soy sauce. Dangerous and disgusting, but the vomiting is really protective in these cases. The issue becomes when the person does not vomit and they absorb all the sodium chloride. So what the team did in this case was essentially resuscitate the patient very rapidly with 6 liters of free water, presumably D5.
Wow.
And that would be in an attempt to essentially dilute that acute hypernatremia back into the normal or near normal range. And this patient did well. They woke up and they had no neurological sequelae.
That's amazing. Oh, terrifying.
Yeah.
Yeah, just don't drink a gallon of anything. There's so many gallon challenges. Gallon of water that's
Yeah.
going to cause hyponatremia. There's deaths from drinking too much water too fast. Gallon of milk is a real challenge. I know of people from school growing up who did that. I think that's a little more protective because you got proteins and fats in there to slow down absorption, and you just can't drink as much. But
Yeah.
yeah, and as a rule of thumb, a gallon of anything is rapidly poor, not a good
Space it
idea.
out. Space it out.
Space it out.
Safer that way. Yeah.
I'd say this, and yet I, as a youth, was once challenged to drink a 20-ounce glass of maple syrup,
Oof.
and I did not finish it. but not even for a moment did I think, could this be negatively impactful?
Yeah.
So we don't all make the best decisions. Really great. All right. Do you want to do another one? I have maybe one more fun one.
Sure. Yeah. I'd love to.
All right. So I just found when I was reading this one, I was like, this is just so interesting. So, okay. A 22-year-old professional gardener was brought to the hospital for detoxification from chronic cannabis use. The patient stayed in the hospital for 3 weeks until going to a different hospital. Not that important. On arrival to the new hospital, the patient announced his intention to commit suicide using poisonous plants. The following days, the patient was allowed into the hospital garden. Not sure that was the best move given what they had announced. Nurses entering his room noted plant material strewn about. The plant material looked similar to pine needles. They were flat, green needles with seed cones, and some of the seed cones had berries around them, I guess, but it's not a great description. I could give you a picture if you want. You want a picture?
I think I know this one.
Okay, all right.
I think I know this one. So kind of taking a step back, a differential diagnosis of something a plant that could kill someone that might be decorative, that might be just casually planted in a hospital garden. So things I'm thinking about would include potentially rhododendron. This is something that can have toxin, which is a sodium channel opener. Very beautiful. Problem with it is these are thick, waxy leaves. It's really not functionally possible to eat enough of that to get sick. There's just these hard, tough leaves. It's just kind of not going to happen. Foxglove classic, gorgeous, beautiful flowers. They might be available, but I think a lot of people recognize those as toxic. In the autumn crocuses will be just kind of around. Those contain colchicine, so that's something that could cause toxicity. But I think what this patient likely took was and that contains
Me?
taxanes. Yeah. Exactly. Yeah, and that's something that it's a decorative bush. It's kind of it looks like a conifer. The leaves, they look like pine needles, and it contains these toxins that are sodium and calcium channel closers, and they can cause cardiac dysrhythmias and death. So that would be my thought.
All right, let's go through the final course and I'll let you nail down. So later that evening, after finding these flat green leaf needles and seed cones, the patient endorsed nausea and abdominal pain. And then a few hours later, a rapid response was called for bradycardia and hypotension. A bedside echo showed, severely depressed cardiogenic shock, depressed ejection fraction. He had shortness of breath. They were beginning resuscitation when he progressed to a wide QRS rhythm and lost pulses. And despite defibrillation, ACLS, and lidocaine and epi, ROSC was unable to be achieved. So, final answer?
It sure sounds like Taxus.
That is correct. The U. I'm glad my description was enough to describe what it sounded, what it looked like. Yeah. It's always tough. But yeah, the yew tree, really a fascinating plant. And what I find so interesting about it, so the yew tree, the Pacific yew, is actually where we get paclitaxel, the chemotherapy from, which a lot of people would associate with hematologic toxicities. It's a cell cycle specific inhibitor of cell replication. So most people, when you think of yew, if you happen to know that tidbit, you're like, oh yeah, this is probably a heme toxin. But no, you die long before that could occur. So taxane A and B, just like you said, calcium and sodium channel blockers, they can cause bradycardia, cardiogenic shock, wide complex QRSs, and decreased cardiac contractility. And that was just an interesting case. I was like, that was one of the forensic ones where they have a very brief description of what happens. And then they're like, and then we detected taxane in the blood. Which they did. But it's a very interesting and scary toxin. We've had a couple of cases over the years. But great job on those. That was fun.
Episode number 22, August 9th, 2023. Dr. Frank Paluchek.
How would you like to kick this up? Would you want to throw a case at me, or would you like me to give?
I'm a creature of chaos, Ryan. You could roll a dice if you want, or flip a coin. I don't care. What's the normal? Is there a normal sequencing your other guests?
There really is not. I like to give. All right, here's the chaos. Yeah. Pick a number between 1 and 10. I'm holding one behind my back.
Yeah.
Oh wait, now
that's 5 then. I don't want to be difficult, but
actually you have to pick a number between 0 and 10.
0 and 10, 7.
Okay, if it was greater than 5, I was going to go first. So, all right, and you have no way to prove that, but this sounds.
I'll accept it. Let's have it.
All right, so I'm going to give you a case. You know what? This is going to be the easiest case that you've ever. And you know what? It's okay. I know you're going to get this immediately, but it's something I want to talk about anyways.
Okay.
I'm going to just ease you in. So, A 31-year-old male presented to the emergency department with sudden onset hematemesis that started about an hour ago. For listeners not familiar, that means vomiting blood. Physical exam and vital signs were completely normal. So heart rate, blood pressure, everything looked good. Nothing wild on physical exam like clonus or, people's are all normal. Everything's normal, except his venous IV sites are oozing after they place them. So he's got blood trickling down from there. Laboratory and diagnostic findings, we have a hemoglobin of 18. An INR was immeasurably high. His urine drug screen.
I mean, I didn't need it, but okay, that I'm done. I'm done. Do you want to go on, or should I say I'm done?
Well, okay. Well,
right.
Would you like to venture, or at least give some differential here on what you're?
Well, sure. Now, when you first started with 31-year-old and hematemesis, only because I like to, we frequently teach something called toxidromes, and in my group at Toxicon, we like to categorize them as poisontations, a poison presentation, where you include the setting along with symptoms, because there are certain things that when you have a 4-year-old who's suddenly found down by the garage during spring cleanup, there are just things that boom, boom, boom. You're going to say gardening products or car products. What's dad doing at the time? He's being a dumbass or something like that. All right. But here I had a 31-year-old and you said hematemesis, and I think you said male. I mean, that's important, although it makes me stop thinking of a female in iron, which used to be something I was deeply afraid of because we saw it all the time. And then you gave me normal vital signs, and I'm thinking, oh, well, if it's a caustic, they're already puking blood. They ought to have some tachycardia from some pain and crap. And then you said the hemoglobin's 18. So, it's up. And then you said the INR is immeasurably high. So it's the right age for substance abuse. We're in the Midwest. We've had periodic excursions with weed that has been contaminated because of garbage on the internet about the enzyme inhibitors that can prolong the activity of CBD or weed and stuff like that. So this is going to be a cannabinoid, and it's been contaminated, and I've got a brodifacoum of some type.
Hi everyone, Toxo here. No, that was not your internet connection. The internet just can't process all of Frank's musings, and it sometimes breaks down a bit. You will hear that once or twice on the show. Just a warning.
So you think some sort of cannabinoid contaminated with brodifacoum, you said?
Yeah.
Correct. Okay.
Yes.
Brodifacoum, for the listeners, I assume most of you will know this, but that is a super long-acting rat poison that it's a super warfarin. Frank doesn't think that this patient took a bottle of warfarin. He thinks that they may have been using a cannabinoid that was contaminated with brodifacoum. So, okay, here's the rest of the case. Patient had a urine drug screen that was negative. Huzzah! Frank's shaking his head. Of course, it's negative. CT abdomen suggested for perirenal hemorrhage. He was admitted to the hospital, started on vitamin K. INR remained unmeasurably high. That evening, he became altered. Sodium was 125. CT of head showed a large frontal parietal hemorrhage with midline shift and herniation. Reversed with some 4-factor and declared brain dead a couple days later via perfusion study and taken for organ donation.
You conveniently left out his past medical history.
He had no past medical history other than he likes to party. There was I'll give you a second to lock in your fine. Does any of this change anything?
Well, I'm gonna go with no. It doesn't.
Fair enough. So the cause of death: hemorrhagic complications of acute brodifacoum intoxication. Blood brodifacoum level 96.5 mic per liter. And he had a history of using synthetic cannabinoids 2 days prior to this presentation with his friends, which you might have picked up and if in the emergency department if you asked the patient, but who knows if they would have asked in the beginning. So absolutely, this was a case of synthetic cannabinoids contaminated with brodifacoum, leading to severe INR elevation and intracranial hemorrhage. Something I know you guys in Chicago got slammed with. We had a ton of it. We're about 90 miles north of you. I don't know if it's exactly 90, but we had a ton of it too. I saw this in the emergency department all the time. Patients coming in. Usually the most common complaint was it was a young male or a young female who just suddenly started urinating blood. And then they would come into the hospital and have an INR greater than 10. And then I would get to go in their room and be like, so what synthetic cannabinoid were you using recently? I heard a lot about Green Giant. That was one of them. But there's tons of different ones that were actually used. I don't know what your experience was, but it was a pretty harrowing experience trying to get these people get their INR down afterwards. So we would start these people on 50 milligrams 3 times a day, sometimes, of vitamin K, which for the listeners, if you're not familiar, that's like 150 times the normal dose. You might put someone on you might urgently reverse someone with 10 milligrams IV, or putting people on 150 milligrams a day. Hard to get.
Oh, God, yeah. It was a hassle.
I think Renee Gimbar, the ED pharmacist at UIC, and Joanne Rutsolius, I think is how you say it, at Cook County.
At Stroger Hospital.
We're really involved in actually figuring out how to get enough vitamin K for this outbreak.
Yeah, very involved. And Michelle at the pharmacy involvement at trying to create some kind of some organized collection, storage, inventory was very key. Yeah, it was horrible. It was horrible. People don't understand how it was a horrible summer for the Tox fellows. They were out collecting samples and doing interviews. They worked their asses off that year because of that. Yeah.
That's unbelievable. Well, and it's a tough patient population sometimes to get to these brodifacoum. You can have people in INR greater than 10 for months to a year after this. I think the half-life is 45 days in whatever, in one random person they measured it in. And so trying to get people to take vitamin K consistently for a year, or however long you have to do, you have to have, case management follow up with these patients.
Plus convince them that evil had been done to their good stuff,
Right. Yeah. Which, thank goodness, I really feel like synthetic cannabinoids like K2 and spice have fallen out of use a little bit. Probably due to legalization of actual marijuana, which I will happily have some oh my goodness, from a drug safety standpoint, is THC 1,000 times safer than these random chemicals people are smoking so they don't test positive on a urine drug screen, which, like this case, this patient didn't test positive for any THC because what they were smoking was nothing like THC. It might actually hit a CB receptor, but it's a full agonist there, and it has 800 times the potency as opposed to THC, which is a partial agonist and lasts a tenth as long. It's just wild. What still baffles me to this day is, how did the brodifacoum get in there? It continues to pop up. There was just an outbreak in Florida, and there was an outbreak in Europe this year.
Yeah, I saw the Europe one. I didn't hear about the Florida. Well, I do think, when it first happened, I got on. Now, I'm not a skilled internet surfer, but there were chat boards 4 or 5 months before the outbreak in Chicago that were in India, where people were talking about mixing brodifacoum because of the drug interaction with the CYP enzymes, and that people should do that. And I wonder if that information in some manner is still out there on Reddit or Arrowit or somewhere, and people are not buying contaminated. They're just somehow doing it on their own. I don't know.
So they think they're using it as a armchair pharmacologist.
Yeah, a facilitator.
I know.
In my day, I don't know if you ever come across this, but I'll just give you a sample of something similar and yet even more baffling. There was a period of time where we were seeing, very limited, but we were seeing street sales and reading about patients of people who were using cocaine with organophosphates. Oh, yeah. Oh, see, I didn't think so. The organophosphate was a cholinesterase inhibitor, and we never talk about the fact that cocaine is an ester, and a significant amount of its metabolism is through plasma esterases, of which a big one is the cholinesterases, and it literally did prolong cocaine activity.
Wow. That's why cocaine is one of the few drugs on autopsy that will post-mortem will have actual metabolism, I think, because of the cholinesterase. So
Yeah.
it's
Yeah.
still kind of hanging out in the plasma, and it'll
Yeah.
continue to get degraded. That's fascinating. The
Yeah.
armchair pharmacology they're pretty smart stuff out there sometimes. Dangerous, but smart. I had heard a theory, at least, if you look at the structure of these of these unnatural synthetic cannabinoids, they're heterocyclic, long carbon tailed compounds. And if you actually look at the structure of Brodifacoum, very similar. So I know there was at least one theory that it's continually popping up because it's potentially a synthesis error that's occurring, and there's basically a small amount of Brodifacoum
that's interesting.
is actually being produced. But I don't think there's a specific synthetic cannabinoid that it's associated with. I think I would have to double check. So listeners, grain of salt here. I'm just pontificating. I think it's been associated with multiple different chemical compounds because there's thousands, hundreds to thousands of these synthetic cannabinoids. So you would think if it was a synthesis error, it would be one specific type, or at least one kind of structural class that seems to be, but I don't know. Anyways, baffles me. It's still popping up, and I hope people recognize the dangers there. Not only that, but the synthetic cannabinoids. I've had young people intubated in the ICU for 5 days from using those, where they go into
the dosages involved are a little different than old man experiences. So I've heard.
Is that so? All right. It definitely, you get wild doses. You can have half-lives that are 1 hour longer than THC to 5 days longer than THC. So you're really, exposing yourself to, and they're full agonists and not partial agonists, a lot of them. So higher intensity, longer duration, and wild dose fluctuations. Also, you can pass the drug test. So, and then you bleed out of
everywhere.
Yeah. So kind of a wild thing. Toxicology is just things pop up everywhere. But that was a fun one. Well, excellent. You hit that one right on the head. I know you have some fun cases prepared as well.
Yeah, I got two, I think, if we have time.
Oh, yeah.
I'll start with the first one. All right. 50-year-old male presents after taking an unstated amount of his own medication for self-harm, and he refuses to tell you the time either. On presentation, he has a blood pressure of 68/46, a heart rate of 133, his respiratory rate is 24, and he has an O2 sat of 97%. His initial blood glucose on point to care is 320. He's agitated, and the EKG's on quick. He's got a heart rate of 129 on the EKG. His QRS is 118. His QTC, which I could give a rat's ass about, is 313. He has a history. He has an incomplete.
Tell me what his T-wave dispersion is. That's what I want.
I'm not. Oh, well, no.
Yeah.
In fact, if you were to look at it and be the expert, as I'm sure you are, you might say this looks like a multifocal atrial tachycardia, maybe.
Oh.
And then you get back initial labs. His sodium's 153. His K is 3.3. Chloride 103. CO2 11. BUN a 95, creatinine a 1.25. Not a simple case.
Okay, well, I could do some pot shots here.
All right, let's have it.
I have a hypotensive tachycardic glucose of 313. That brings up calcium channel blockers, specifically amlodipine, right? We have a non-dihydropyridine. You vasodilate, you get reflex tachycardia. It does not cause, until you get to the high doses, the bradycardia and AV block and depressed ejection fraction that you see with Dilt and verapamil. And then, of course, you get pancreatic calcium channel blockade. For everyone out there, calcium is the player of all excitable cells. You have sodium depolarization, but sodium is like the roadie. It's like getting the stage set up. It's really there to let calcium do its job, which is bind to vesicles and then bind to the membrane and release whatever neurotransmitter or insulin, for instance. Or in the heart, the calcium is what does the contraction. So when you inhibit calcium, especially at the pancreatic cell, calcium channels, if you inhibit the influx of calcium, you inhibit the release of insulin, and thus you get hyperglycemic. So I'm seeing a patient who has a hypotensive tachycardic with a high glucose. That jumps to mind right away.
You got to.
And I can't really prove it. There's no urine amlodipine I can do. But let's think what else could be here, just because we got to think further. So the QRS is 118, and he does have a lower potassium. So what else can cause, it's not super low, but it's low. So what else could cause low potassium, hypotension, tachycardia, and a wide QRS? I'm thinking of the chloroquines, hydroxychloroquine can cause that. It actually sort of causes a low potassium potentially via increased insulin release. So the glucose is higher, but maybe he's got diabetes, who knows? I'm thinking of other things that lower my potassium. Barium, I don't think that's going to go on. I'm probably hinging too much on this.
I'm giving you a verbal clue.
Yeah, a non-verbal. Yeah,
no, it's not a non-verbal clue.
Now the only other thing is, what is the sodium of 153? And I'm trying to think, is this guy just like, is there some drug that has sodium in it? Not really. Things that can cause hypernatremia are usually dehydration. Does he have lithium-induced diabetes insipidus?
Oh, that's very nice.
I think no. I mean, no, not from an acute.
It's very nice. Yeah, it's a nice. I did not expect that. I like that a lot. It's no, just so you know. Yeah.
Okay, all right, but good to know.
By the way, while you're thinking, because it takes time while you're at the bedside doing this, you can't help but notice how tremulous his fingers are.
You theophylline-loving old. That was the other one, is that this has got to be beta adrenaline, well, whatever, increased 6-potency monophosphate, driving potassium down. You get tachycardic, hypotensive, you get beta 2 basically stimulation and beta 1 stimulation. Drive potassium down, you get tremor. That was actually, I forgot to, methylxanthines, of course.
The case really did have some red herrings in it.
Yeah.
That I think the fact that you gave me a diagnosis I hadn't thought of myself, I just figured it was appropriate.
Okay, so let's dialyze them or whatever you do. I rarely see theophylline.
See, that's it's you have the old man on, so he wanted to show off that he used to be able to do something. You could ask for dialysis. You could. He's not puking. You could certainly go down the charcoal pathway here. But when I started, theophylline and iron were by far the two most feared ingestions we had. We didn't have really very many calcium channel blockers on the market, and they were all immediate release. And in the early days, immediate release for Verapamil, immediate release, any beta blocker, and I'm even saying propranolol, they were like boring. Nobody cared. They were hypotensive maybe for a little while. Nothing happened. Wow. And the sustained release products made them the ugliness they are now.
That's correct. I mean, right now, yeah, and you should a propranolol or a Verapamil overdose, and my toxic sphincters are clenching.
Yeah.
So theophylline must have been
it was
wild ride.
Man. It was really, really bad, but it was one of the best overdoses to teach toxicology with. You had every decontamination method had things you could talk about. The sustained release pills were so big that they wouldn't go up a lavage tube because so many people believed in lavage. Charcoal could decontaminate beautifully. Charcoal could enhance. All the original enhancement literature was with charcoal. Hemodialysis worked. Hemoperfusion worked, but you had to guess when the cartridge would saturate and then guess when to pull it out and replace it. What would be the novel and exciting treatment for the hypotension?
For theophylline? Novel and exciting. Well, because it's toxicology and you said novel and exciting, I'll say fomepizole, but that's not the answer.
No. Well, maybe not so novel. The predictable but no one would let you do it treatment would be, of course, to push propranolol.
Oh, that does make a lot of sense.
And it worked. And this, Ryan, it was so much fun. But the reason it was sphincter tightening was the seizures. These were not normal seizures. This is INH quality nightmare. And I am old school enough to say I try a couple of doses of my benzo, and then one of the few times you will ever hear me say this, I can't wait to jump to barbs. I'm going to put them out, down, just slab them out, and let them lay there for a couple of days while the liver does its work. They were bad. They were really bad. And anyway, I had to go with theophylline. I just had to do it.
I love it.
Caffeine has not gone away, and we don't see as many caffeine challenges.
I am curious, was there a concentration associated with that?
150,
One?
150 milligrams, which, over 100 is really kind of interesting and exciting, and you're getting there. They don't normally make it to the 200s. They're normally dead or in care. It's bad. The highest I've ever seen reported, there was a case of a screw up with a neonatal hyperal or an infant hyperal. They were trying to treat the kid for an infection with ampicillin and grabbed the aminophylline, which was next to it. And the kid had a level of 330. And the nurses noted didn't feed well and was a little more jittery than usual, but did fine.
I do feel like theophylline concentrations are a little bit like salicylate. Like greater than 100, you should probably be nervous, right? 30 is kind of your therapeutic upper, range. And then between there, chronic, if you're chronic, you could see some pretty nasty stuff.
Much lower, yeah. The tank's already partly full.
Yeah.
Target organs have too much in them to begin with, yeah. And then you get that big hit right away with the beginning of the absorption. And, yeah.
Interesting. Okay. Well, that was excellent. Theophylline, great case. I got another one for you.
Okay.
All right. Well, this one could be fun. It's sort of the season for this. It's actually a little late, but we'll see. 4 family members presented to the emergency department from their farm. They all developed symptoms around the same time. They had come in from working on the farm. They had also eaten a meal. They found themselves 2 to 3 hours later to be irritable, exhausted, abdominal cramps, diarrhea. On presentation to the emergency department, 3 out of the 4 had cramping, salivation, frothing from the mouth, sweating, lacrimation, blurring of vision, meiosis, ptosis, bronchorrhea, cough, wheeze, tachypnea, bronchi, bradycardia, and hypotension. Also known as the cholinergic toxidrome, it appears. So they work on a farm, and then they all shared a meal. And here they are, 3 hours later. What do you think?
Well, I want them to be sitting out in one of the meadows, having a family picnic, and a crop duster flew overhead and sprayed them with pesticide, but it just doesn't sound like that. In all likelihood, this is somebody, they had a meal. The options are mostly going to be from my limited urban experience, because this is something I don't get to see, or we don't do very often at all here in Chicago, is that there could be granular forms of organophosphates or now I'm having old man brain fart. The other ones.
Carbamates?
Yeah, carbamates. Thank you. I kept wanting to say pyrethrins, and I said, no, we're not talking about insect repellent. And the toxidrome is wrong. But it could have been a liquid, because we tend to see more of the liquid exposures. We've had some really interesting ones, but the liquids are all hydrocarbons. They smell like crap. It would be really hard for me to think all 4 family members would drink one of these as mistaking it for somebody's punch or water or something. So someone had misfilled a salt or some other condiment container with pesticide. That would be where I would go with this first. Now wait. Oh, I know this isn't the case, but I do want to ask: is this happening in China? And is their farm really prosperous compared to their neighbor's farm? And somebody went out and got some tetramine and mixed it in with the flour or the sugar that they made their meal with. Except it's probably not China, is it?
It's not China, and there was a clue I kind of excluded because I wanted you to bring up organophosphates. It brings they're on a farm, right? So we got to think about insecticides, pesticides, herbicides, all those.
You have to think that first, yeah.
They happen to eat a meal prepared by someone who foraged some things.
Oh, I missed it. Now, having grown up, my last name is Czechoslovakian in origin, and my grandfather is a Chicago native Czechoslovakian person, which we have Hobie festivals here, which is a celebration of the mushroom, and we go We go foraging through the forest preserves of Chicago hunting for mushrooms. So I'm going to guess we're going, but it's one of the bad mushrooms. And somebody picked an amanita or one of the other hepatotoxins. And that would be the reason that you're giving me this case, because it's probably a death abstract and it's one of the recent foraging bad ones with the family. Yeah.
It is a bad one. It is not an amanita.
Yeah.
And nobody in this one died.
Well, then, no. So they either had markedly hyperadrenergic vital signs or they had kidney failure.
Neither.
Damn it. All right, you're going to have to tell me. I yield to the gentleman from Wisconsin.
Cleidocybe mushroom.
Oh.
The muscarine containing mushroom. It actually has muscarine, which, as most people know about muscarinic acetylcholine and nicotinic acetylcholine, this is where we get our muscarinic receptor from, is that those muscarinic acetylcholine receptors are more susceptible or more bound more tightly by muscarine than they are nicotine. Kind of a one-off one.
We talk about it when one of the rotators or fellows presents mushrooms, but I'm one of my mini rants is they start talking plants and I go, I don't do natural things. And I turn away.
Frank is unnatural.
Thank you. Oh, I like that.
Well, so I brought this one up because I don't know, mushrooms are kind of fun. Yeah. Wisconsin has a plethora of weird ones, and we do have cleidocybe. Inocybe is the other species or genus or whatever. I'm screwing that up, but cleidocybe and inocybe mushrooms both contain muscarine, and we've actually had a couple cases, including some fatalities from cleidocybe. And my colleague, Dr. Matt Santon and Drs. Amy Zosel, they wrote up a whole case of one where it was a misforaging adventure, and they actually got the mushroom out of the stomach on autopsy and spore printed it, and ended up identifying it as cleidocybe. That's why it was kind of interesting. So if anybody interested, cleidocybe or death related to cleidocybe mushroom from foraging, I think is the name of that case report. But in this one, we had 4 family members. They all ate the same mushroom. They all developed cholinergic syndrome from the muscarine within the mushroom. 3 of them had to be atropenized. So they were given boluses of 3 milligrams of atropine, and I think started in an infusion. And then, so for atropenization, which I've really only ever had to do twice, or and by do, I mean talk to people about doing over the phone. It seemed, it's kind of a terrifying thing. You're giving big doses of atropine, and you're titrating it to lung sounds and resolution of bradycardia, which is all good. But then sometimes I've had people end up with urinary retention from it, and I don't know. It's kind of a thing. These people were given atropine as a bolus and infusion, and then they resolved in about 10 hours. But the other definite thought is, farm organophosphate, right? And then you can run into quite a lot of issues. But mushrooms are always fun. We get a ton of calls in the spring and the fall, and always a fun thing to talk about.
It's a case like this that, to me, as a predominantly EM person, when I was a clinician, versus I've never spent a day working in a poison center. EM pharmacists, they'll know a lot of the stupid street drug crap because a lot of it never gets called to a poison center. No urban EM pharmacist, is going to go out of their way to memorize all the mushrooms because they don't see them or they can't retain it because of cases they've seen or they know. You have to have an EM person or a clinic person think of calling toxicology.
Yeah.
I'm terrible with mushrooms. The only thing I know for sure is that we easily appear to be able to grow inky cap around the campus buildings of the University of Illinois Hospital and Medical Center and John Strozier Center. And on occasion, if we ever wanted to, should we ever have alcohol at work, which would seem incredibly unprofessional and unlikely, that we could have an inky cap disulfiram reaction outbreak, but it's never happened somehow.
Nobody's gone mushroom foraging post work.
No, we've had some digitalis, mild, but not. We may have been involved with, maybe one of us, not me, I don't do natural, would like to bring in fresh flowers in spring and ask people to try tasting them to understand what kids may or may not be doing. And it once may have involved some lilies of the valley, and the people that volunteered to try chewing some, one of them may have been about 4'10", 4'11", 70 pounds, maybe.
Sounds a bit like an ED pharmacist at UIC.
And maybe that colleague, this person that I know, who's, might have been short and tiny and blonde, maybe got somewhat symptomatically bradycardic within the hour. This is the stupid things that tox people do.
Yeah.
We once set the roof of the ceiling of our conference room on fire. It was one of those dropped tile ceilings. The building's gone. We were doing mothball testing.
Oh my
Bunsen burner. we set it on fire. Oh God, we were crazy. So your audience should be gathering that old people that did tox, not normal and never should be relied upon for good cognitive decision making.
I don't know. You gotta test the boundaries. I think there is a lot of self-exploration in talks, right? You gotta find out what the mothballs look like. You gotta put a battery in a pig esophagus. You gotta see it all firsthand. That's pretty great. Well, that is a fantastic story.
Have you had a water hemlock or any of the other classic?
No, I mean, I've had plants. I've had some interesting plants once in a while, but never a water hemlock. That would terrify me.
Yeah.
At least based off what I read.
We've had some fugu. We've had some tetrodotoxin, not too many, but a few, and a fair amount of ciguatera, surprisingly enough. People vacationing, and a couple of scombroids that nobody wanted to test to confirm, but I don't know what else it could have been. So actually, I feel more comfortable with marine seafood poisonings than I do mushrooms.
We had a lot of palytoxin at one point.
Do you?
People cleaning out their zoanthid coral fish tanks, boiling the coral. I feel like a couple of years ago, there was a whole bunch of outbreaks of palytoxin for some reason. And we get algal blooms and, plants we have, I get a kid eating lily of the valley all the time and nothing really ever happens. But plants are fascinating. And so I feel like in EM, you use 99% of what you use 1% of the time. Yeah. And in tox, it's like 99% of what you use 0.001% of the time.
The flip to that, Ryan, would be to say the 1%, the 99% that they never use in tox is about 90% of the time the stuff we have to know, that it's the weird stuff that everyone else forgets. Yeah. Well, are you ready?
Oh, I'm ready. Let's do it. I'm ready for it.
All right. Now, I'm not trying to be inordinately kind, but I will give you forewarning. This is not common.
Even better.
Because we don't think of it as common. But I think from a tox standpoint is an incredibly important thing that we do need to be a little bit better about educating people on. All right?
Okay.
So don't think normal tox. You've been very kind so far. Mushrooms, I'm supposed to know. I just don't give a rat's ass. The brodificum was, thank you. I am in Chicago. We play with 16-inch softballs. I'm glad that you gave me one of the big puffy things for me. All right, here we go. Are you ready? Now, I've modified this slightly from the case, and you have to tell me whether you want me to send the cases or any materials that I reference if you would like.
Oh, yeah.
So this is a 34-year-old male who, where did it go? Who presents to the emergency department with a lesion of his penis for the past 2 days. It's pussy. He scratches it. It's just not constantly leaking pus. And he's got and he says, "I think I've been bitten by a spider."
Okay.
What would you like? I will provide you what limited information you may. I know it's wide open, but I'm trying to.
Did they ultrasound the penis? No, I'm just kidding.
No, they did not ultrasound the penis. Yes.
Well, okay. I assume this is so. Hold on. 34-year-old male.
34-year-old male.
Emergency department. He's got a purulent penis
lesion.
Eruption. We're gonna call it.
Zit.
A zit. Okay.
A zit, perhaps.
Oh boy. All right. And I mean, it's tox, but as you say, it's all tox. So we, immediately I think potential sexually transmitted
I hate you.
Infections of sort. Well, what else is a lesion?
Keep going.
Okay, I had this old mnemonic. I got to think of it again. Okay, painless and pusless is syphilis. Although HPV warts and I guess like malignancy could fall into that. And I guess we're just talking about a single lesion here because there's also like pearly penile papules and all that weird stuff that I really don't know. Painful and pussless is herpes, and painful and pussy is chancroid. There's another one, molluscum contagiosum, I think, is the other
Oh,
one.
wow.
It's like, but I think you have multiple lesions. And I don't look at a lot of penises up close in the emergency department. I'm just rifling through my penis differentials here. Now, so syphilis would be my first. I mean, does he have neuro symptoms? Is this
All right. So they send a test. They're waiting results. Anything else?
Yeah, I want my VRDL, my dark lab, whatever that stuff is.
Oh, it's
Anything
negative.
else I want?
Anyway,
I'll do
moving
everything.
along.
We're gonna send a full panel: GC, chlamydia, HIV.
I am already extremely happy that I chose to do this.
I want to know a basic metabolic panel. Is there anything
Normal. They didn't even bother drawing one, but it was normal.
Okay. Urine, I guess.
Urine looks normal.
Okay. I'm trying to think what else I would even want here. I mean, I don't know what other labs other than STD testing are going to be of value.
As an emergency department pharmacist, while you may not be performing physical assessment, have you ever found it useful to conduct a more thorough history taking of a patient?
I have found that this is sometimes useful. I do want to know, does this guy have like really nice thighs or like really big calves? Does it look like he's potentially augmented any of his musculature?
Oh, that's a very lovely thought. And you could maybe even be in Miami and wonder about whether he seems to be concerned about the cosmetic appearance of maybe his backside and things like that too. There was just a case in the news of a guy who did not do so good trying to enlarge his penis with silicone. No, it's not that, but I like that thought process.
That would be
there. He doesn't have lesions anywhere else, nothing on his back. There's no striae, and he looks rather normal in musculature.
Okay. All right. So not a silicon granuloma, which wouldn't be purulent anyways. So I am pretty stumped right now.
I meant to stump you.
Which I appreciate. I like to learn. So what am I missing here?
Okay. So you're going to ask if he's ever had this before.
Yeah. Okay. Yes. Has
Okay.
this ever occurred before?
He said, yeah, about 4 years ago. They thought it might have been an allergy at the time.
Allergy to what?
Well, I don't know. The only thing I was on Bactrim at the time, and they said maybe I was allergic to the Bactrim, but I haven't taken Bactrim since.
Okay. And what have you recently begun? What have you done differently in the last week? Have you changed any of your foods? Have you started any new medications?
Excellent. And you're going to go down that pathway of potential allergy, and you're going to get. Well, I don't know what all your questions are, but food, detergents, cosmetics, perfumes, animals, children, home, paint, all are negatives.
Any new sexual partners?
No, just his wife. He's always been monogamous.
Does your wife have any new sexual partners?
I doubt it.
Okay. Just so I can
I don't think so. I'll call her and have her come in.
Okay.
Yeah, and then you'll ask her in front of him, and she'll say no. Which the mother-child phenomenon in the ED with drugs of abuse. Yeah. Oh, you're close.
I'm close. Oh boy,
Yes.
Have you bought any new sexual devices?
No. Now you're getting cold again. So
we're
going to ask him. Well, is there any Bactrim in the house? Is there any cotrimoxazole or trimethoprim sulfa in the house? And yeah, my wife is taking it. She has an upper respiratory tract infection, and she's been taking it for 3 days. Yeah, I see those eyes. I think light is dawning.
This is bananas. Are we talking about potential mucous membrane, I guess vaginal mucous membrane transmission of Bactrim?
Ryan, I am so happy right now. So
I would never be able to dive that far.
So let me give you a capsule summary. This is an interesting area to me. I did a talk at NACT many years ago, and I called it coitus rigor mortis. And so just like with the Alphalin, I stuck to my personal passions that I think people don't know enough about. And it turns out that particularly with antibiotics, that we use to treat reproductive organ infections, don't we? That they concentrate in those organs, and as a consequence of being able to concentrate in those organs, they are found in the exudates and or fluids associated with those organs and their glands, and that it is documented with some pretty interesting cases that you can have anaphylaxis or localized dermatologic allergic reactions because of exposure to the reproductive fluids of a partner, male, 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 female, female, female. And it's much more likely than with kissing because you get much higher concentrations in those organs than you do in saliva itself. Now, in this particular case, they said after several hours, they asked, have you had recent sexual intercourse? He'd had it 3 days before. She was on it for a sore throat. They did a microscopic examination of a lesional biopsy. They showed liquefactive degeneration of the basal layer, all consistent with a fixed drug eruption, and they ruled out herpes simplex infection. They were unable to get the lab of the hospital to agree to test vaginal fluids of the wife for concentrations of cotrimoxazole. So they got consent from the consorts to give the wife a 960 milligram tablet, and they requested that the patient have intercourse with his wife without condom or contraceptive barriers. And 4 hours later, he had itching and a new lesion. So you have a de-challenge, re-challenge. I have Jill and I and Renee have worked slowly over years, worked on collecting as many of these as we can, and it's confounded by there's no standardized term, it isn't recognized, but I've seen real cases of sexually transmitted poisonings involving ciguatera. It's well described in the Pacific medicine literature as something to be very careful of. It causes severe dyspareunia, severe pain on intercourse with ejaculation in men, and I think the whole area is we can't forget that we can be exposed in these mucous membranes with very, very thin dermal layers, that the potential exists. There's some corollaries, like you might be on a cream and not wash creams or ointments off at night, and it'll get in the bed linens, and then it gets on your partner. And a common version of this is with acne, the exfoliatives, where it gets soaked into linens for people who don't do their bed linens very often. And then their partner works up with this one-sided unilateral reddening of their skin and rash, which is just them exfoliating because they're just getting all the stuff. It's really cool stuff, Ryan.
That is unbelievable. I think everyone just added something to their differential here, and that I will be very surprised if many people knew or had this in.
I don't think they do, and I think it's there's two reasons. One, anaphylaxis is incredibly rare,
right? So
we don't see the ones that really make us alert to it, and we just assume it was something that they forgot that they took. We don't think of the intercourse. And the other is the most common manifestation you'll get will be a man or a woman who has a localized rash to where reproductive fluids would be, and you're going to get diagnoses like nonspecific bacterial vaginosis or heat rash or bad hygiene, and no one bothers to look. But there's stuff out there, and there's some people have done some testing of seminal fluid and things like that, and it's a real thing.
Thank you for teaching me that.
Always glad.
All right. Well, we only have a little bit of time left, and I really wanted to. Those were great cases. And
thank you.
I think a lot of good
ones too. Yeah. Classics.
I wanted to, instead of doing questions from the internet, we're going to do a different segment. And I really wanted so this segment is really, this show is where tox nerds get on to talk about tox. So why not talk about what's interesting to them in toxicology? And I want to hear from you, Frank, but there was something I really wanted to do. And this is what I'm interested in the future here of toxicology. And it's there's a lot of interest in the intersection of artificial intelligence and toxicology. So what I'm interested in is high fidelity toxicology training. And I think artificial intelligence is really going to help with that. So I was playing around with ChatGPT, which is just one of many AI language models. And I eventually footed the bill for like the fancy one that's connected to the internet and everything. And I did something with it where I said, I want you to select a drug or toxin that someone might be poisoned with. I want you to pretend to be that patient who has been poisoned by what you selected. And you can chat with me, but only divulge information if I ask. only reveal the drug or toxin to me if I ask for the final diagnosis or if I guess it correctly. And if I ask you for vital signs, lab values, or imaging, please use evidence-based information to display that data for those results based on the substance you selected. So I had GPT choose a toxin, pretend to be poisoned on it, and pretend to be a patient. And I had a lot of fun doing this with our fellow. We have a toxicology fellowship. I tried this out with our fellow. I kind of wanted to do one of those cases with us together right
All
now.
right.
What do you think?
That's a phenomenally good thought. Let's go.
Want to give it a try? Okay. So the last time I did this, the first time I did it, it chose fugu, some tetrodotoxin. The second time it chose green tobacco sickness, which I thought was really interesting. From people who go out in fields and pull tobacco leaves, and when they get wet, the nicotine concentrates in the dew. So, right, I don't know what they've chosen, and neither do you, Frank. So I'll read out the responses here.
I can see them too, but go ahead.
Yeah, but for the audience.
Toxo here. Despite what Ryan just said, it will actually be me playing the role of the patient. I'll be reading aloud all of ChatGPT's responses to Ryan and Frank's questions. Get ready for the performance of a lifetime.
I am typing into GPT. Can we do it again? All right, here we go. ChatGPT says,
I'm feeling really unwell. I have severe abdominal pain and I've been vomiting. My muscles feel weak and I've been experiencing bouts of diarrhea as well.
so we can ask it whatever we want. Anything you want to ask? I guess kind of want to know when it started.
Yes.
So when did these symptoms start?
The symptoms started about 5 to 6 hours ago, and they've been progressively getting worse.
Anything you want to
I
know,
want
Frank?
to know what medications are you on?
What medications do you take? Okay.
I don't take any regular medications. I try to live healthily, exercise, and eat a balanced diet.
Okay, good for you. I'm going to ask about herbals. This sounds like somebody, taking their nutraceutical that's got T4 and T3 in it or whatever. Let's see. Do you take herbal supplements?
Yes, I do take a herbal supplement daily. It's a wellness blend of various herbs that's supposed to boost energy and immunity.
Oh, they take a wellness blend, but I don't know why that would suddenly cause abdominal pain. That's not super useful.
I'm unfamiliar with this. Can I ask them if they've had any abdominal imaging done?
And you can ask really anything. Would you like an X-ray or a CT?
I'd like an abdominal CT.
Okay. Can I see the results of an abdominal CT?
Sure, the abdominal CT scan shows generalized inflammation of the intestines and stomach, which is consistent with gastroenteritis.
I do feel like GPT leans towards pretty common things that are thought of as poisons.
Well, the herbals, contamination with lead is actually not uncommon at all. If they were going with tox cases, I think it was a reasonable.
Yeah.
I'm not being I'm being risk taking here and going for specifics rather than trying to narrow.
So you're thinking like an Ayurvedic kind of thing?
Yeah.
Certainly.
Plus, you never know where the damn plants are being grown that they're doing and where they were.
Right.
Yeah.
Let's see what they do for work. What do you do for work?
I'm a botanist. I work mostly with identifying and categorizing new plant species.
Okay. They always have really interesting jobs. One was a chemist. Another one was a farmer.
Well, so we've got pesticides in play. We've got self-harm, and he ate some of his plants in play. And we have accidental, another foraging, perhaps, shall we say, accidental meal contamination.
Right. And with gastroenteritis, so it's acute onset, progressively getting worse, kind of makes me think of food. And I bet you this is, all right, let's see. Did you eat anything different than normal today?
I did have a salad for lunch with some plants from my own garden. I frequently use plants from my garden in my meals.
Well, Frank, nice job on that one.
I want an EKG.
Can we see the results of an EKG?
And it's because it's evidence-based and it's going to rely on the literature. I want to know if it's seeing any funny colors anywhere.
All right. Well, I asked for an EKG and a BMP. Okay. The QRS 80, QTC 440, PR 160. They didn't give me I'll ask for vital signs, but I think we have a telling sign right here.
Yeah.
So I asked for a basic metabolic panel. It says sodium 140, chloride 102, CO2 22, BUN 15, creatinine 1, glucose 98, calcium 9.5, potassium is 5. Are you seeing any visual changes?
There it is. Green, yellow. Come on.
Now that you mention it, yes, my vision has been a bit blurry. I thought it was due to the fatigue and didn't pay it much mind.
It's not what I was
Yeah, I thought I was going to get some xanthopsia here. All right, hold on.
Nice word.
How about, right? That's a $20 word. How about, I mean, we think this is digitalis of some kind.
You had, yeah.
I wonder if she was smoking toad venom. Bufadar.
Some Stoneheart at the herbal shop.
Yeah. All right, I'll ask for a vital. We should have asked for vitals right away. I didn't even think about that. Just to confirm. And we're betting that she's going to have a slow heart rate. Can I see your vitals?
Sure, here are my vital signs. Blood pressure, 110/70 millimeters of mercury. Body temperature, 99.3 degrees Fahrenheit. Respiratory rate, 20 breaths per minute. Heart rate, 110 beats per minute.
110?
Oh, that's
maybe. Well, see, ChatGPT certainly has limitations, so I wonder if this is right. With a heart rate of 110, what else could we be potentially missing? I mean, gastroenteritis. Nausea is really common. I don't know about diarrhea. Other things that can cause gastroenteritis. Well, there's really quite a lot of things. Ricin. This could be castor beans. Nausea, vomiting, and pain.
That wouldn't have been those are huge plants. That would be stupid to have a botanist.
That's true. This is true. I wonder if this is just all right, let's just shoot our shot and see if this is what plant do we think? Oleander, lily of the valley,
foxglove. Or oleander. I could go with either one.
We'll go all 3.
Yeah.
Okay. Did you ingest oleander, lily of the valley, or foxglove?
Yes, you're right. There were leaves from the foxglove plant in the salad I ate. I've been poisoned by digitalis, a substance found in foxglove.
Okay, well, we see some limitations here. It was pretty correct, except this.
Well, okay, now wait. I'm gonna fight for the ChatGPT, right?
Okay.
This is within 4 or 5 hours.
True.
You're getting local GI effects.
Yeah.
And it has a slow distribution time into the heart. Dig is a nasty drug for that. So maybe we just haven't quite gotten far enough out to have the bradycardia.
That's a great point. We're just seeing the GI initially, and she's dehydrated from the diarrhea, so we have a reflex tachycardia.
Because with that cholesterol nucleus, it's such a big P-glycoprotein substrate that it takes a while to get enough in. I'm fighting for ChatGPT. I don't know why.
So you'll get a good place once it becomes our overlord. It's gonna put you in on that. But isn't that fun?
That's fun.
That really was fun. Thank you so much for listening. I so appreciate our listeners who make the show what it is. If you liked what you were listening to, or you found it useful, or even if you didn't, leave us a review. It helps us reach other people interested in toxicology. You can always follow the show on social media at tox_talk on Instagram, at lab poison on the thing I refuse to call X. You can follow me at empoisonfarmd. You can follow us on Facebook at The Poison Lab. And you can always write into the show anytime you want with comments, critiques, pictures of your dog, whatever you feel, at toxtalk1@gmail.com. And don't forget to check out the website, www.thepoisonlab.com, where you can find all free episodes, games, resources, as well as a store where you can buy some stickers and other cool swag if you feel like repping the show. Thanks for listening today. I love this show, largely because I love the community that it has. So thank you so much for listening. I hope I can catch you next time. Toxo, can you play us out?
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. The opinions expressed on this show do not represent those of our employers. This show is poorly written and shoddily produced by Ryan Feldman. Don't forget to give it a share with your nerdy friends. Cheerio, mates. See you next time.